So I'm here today to discuss our results of a follow-on from the randomized phase 3 BMT-CTN 0901 study. This was an important clinical trial in transplant for patients in remission in AML who were randomized to one of two conditioning regimens, either myeloablation or reduced intensity. My laboratory at the National Institutes of Health in Bethesda, Maryland, focused on measurable residual disease. And we had the hypothesis that the high relapse rates seen in those who had reduced intensity conditioning may be because of MRD in those patients. And so that's what we tested, and that's what we're presenting at this meeting today. So conventionally, clinical MRD, measurable residual disease in AML, is measured by flow cytometry or PCR. We couldn't use either of those methods because of the sample source we had available. We had blood that was frozen, but not in a viably manner that we could use for flow cytometry. So we had to adopt next-generation sequencing, next-generation sequencing is something that hasn't been clinically validated for the use of MRD in AML, but it's something we specifically tested and benchmarked for this study, so we could get some sense of how much residual disease these patients had. Yeah, so we looked at a set of variants which are commonly seen in AML, and so we were looking for the detection of any one of those variants which had been previously seen in AML patients. The study was a particular technical challenge in that we didn't have any information about the information of diagnosis for these patients. We had a single sample prior to transplant of patients in remission, so we had to do discovery of variants using next-generation sequencing at a very low level, which is extremely challenging to do. So our endpoint was the detection of any variants which has been in our small panel of 13 genes that has previously been associated with AML. And we found that many of the patients did have one of these variants detectable at a threshold down to 1 in 1,000. Yeah, so really interesting. There was a really striking clinical result, even in the early analysis, which is why we brought this to EHA for the late-breaking abstract, and we're delighted it was picked up for the presidential symposium. But it was really striking, and so those patients who had no evidence of a variant detected, and this is over a third of patients, had equal survival regardless of which arm of transplant they were randomized to. And so whether they got myeloablation or reduced intensity, their survival was statistically equivalent. It was just in that group that had a variant detected that there was a clear difference in survival for those who got reduced intensity conditioning. And so even before we look at the different kind of variants, and we think these variants have different significance in terms of prognosis, just looking at the presence of any variant, there was a clear detriment of those people who had a variant detected who got a reduced intensity transplant, both for increased relapse risk, but also for decreased survival and decreased overall survival. And so before even any additional analysis is done, the results really statistically clear in this trial. So we thought it was important to bring here as a late breaking. I think it's for others to decide how much this changes the standard of care. But as a leukemia doc, I'm very excited about this idea. It really helps us identify a high-risk group of patients. We knew that reduced intensity conditioning wasn't an appropriate therapy for some patients, and it does seem like those patients with MRD did do worse on these samples from this randomized trial when they got reduced intensity conditioning. For me, if I was a clinical trialist, that would make me very excited. I would start thinking about randomized trials to really help that group. Because I think for the other groups there may be equivalence between the approaches, but for that group who can't get a myeloablative transplant for whatever reason, but have MRD, that's a really unmet need, and I think that's where the future randomized trials in transplant should really go, is looking at that group and how we can best help them. All we measure is the sample of blood we get in the tube, and so we're not measuring residual disease in the patient. I think that's important to stress. We're measuring any trace in the small amount of blood we receive in these patients. The sensitivity we look for in sequencing, typically for next generation sequencing, they will limit calling any variant above a 2% or a 5% level. We needed to go much, much deeper to look at measurable residual disease, and that's a challenge because there's a lot of false positive results in next generation sequencing. And so we've set the threshold at 1 in 1,000, which we think is a meaningful threshold. But for some variants, and specifically the variants with known prognostic implications, NPM1 mutated, FLT3-ITD, we were able to go much deeper than that. And so we're probably fivefold deeper than that in those variants because of the nature of those variants. Those are insertion deletions rather than single point mutations. What the exact cut point for sensitivity needed for that test, I think is going to be continued to be refined over time. But technically, this is the limit of what can be done with current sequencing technology. It's not possible to push the sequencing any further than where we are now for these variants. So yeah, we did a tremendous amount of sequencing for this study, and it's at the moment I think it's probably not feasible to directly translate this to the clinic. There are next generation tests available for tracking these mutations in AML, but their sensitivity is really ideal for the time of diagnosis where there's a high burden of disease. To get reliable calling of variants, especially where there's no knowledge a priori of what variants you're looking for, requires incredible sequencing depth, and we'll show that today. And so the consensus international recommendations, which were published last year, actually don't make any mention of next-generation sequencing for exactly this reason. As investigators, we're using it, but clinically, there's still some way to go to really work out the rules of how we can best use this technology.